Welcome to the introduction of our video on non-ST segment elevation myocardial infarction, NSTEMI. We'll cover its definition, pathophysiology, clinical presentation, diagnosis, management, complications, prognosis, and emerging therapies, equipping you to handle this condition effectively in practice. NSTEMI refers to a type of heart attack that is characterized by partial blockage or occlusion of one or more coronary arteries. Unlike ST segment elevation myocardial infarction, STEMI, NSTEMI does not show the classic findings of ST segment elevation on the ECG. Instead, NSTEMI presents with changes such as ST segment depression, T-wave inversion, or no significant ECG changes at all. Additionally, NSTEMI can be further classified into subtypes based on the presence or absence of elevated cardiac biomarkers, such as troponin. The development of NSTEMI involves multiple pathophysiological processes. Atherosclerosis, a chronic inflammatory condition characterized by the formation of plaques in the arterial walls, plays a crucial role in STEMI pathogenesis. These plaques can rupture, leading to the exposure of thrombogenic material and subsequent platelet aggregation. The formation of a thrombus can result in partial or intermittent coronary artery occlusion, leading to myocardial ischemia and subsequent NSTEMI. Patients with NSTEMI often present with chest pain or discomfort that can radiate to the arm, jaw, or back. The pain is typically described as a squeezing or pressure-like sensation and is often associated with significant distress or anxiety. Other associated symptoms may include shortness of breath, diaphoresis, excessive sweating, nausea, and lightheadedness. It is important to note that the clinical presentation of NSTEMI can vary greatly, and some patients, particularly women and the elderly, may present with atypical symptoms. The diagnosis of NSTEMI relies on a combination of clinical presentation, ECG findings, and laboratory biomarkers. The measurement of cardiac biomarkers, particularly troponin, plays a crucial role in confirming the diagnosis. Elevated troponin levels in the blood indicate myocardial injury and are indicative of NSTEMI. Additionally, the ECG may show ST segment depression, T-wave inversion, or no significant changes, further supporting the diagnosis of NSTEMI. Several risk stratification tools and prognostic factors have been developed to assess the severity and prognosis of NSTEMI patients. These factors include the patient's age, comorbidities, hemodynamic stability, electrocardiographic findings, cardiac biomarker levels, and the presence of other high-risk features such as recurrent ischemia, heart failure, or hemodynamic instability. Risk stratification helps guide the management approach and determines the need for more aggressive interventions, such as coronary angiography and revascularization. The differential diagnosis of chest pain in NSTEMI includes several other cardiac and non-cardiac conditions. Cardiac causes of chest pain that need to be considered include unstable angina, STEMI, pericarditis, aortic dissection, and pulmonary embolism. Non-cardiac causes that can mimic the symptoms of NSTEMI include gastrointestinal disorders, for example, gastroesophageal reflux disease, musculoskeletal conditions, for example, costochondritis, respiratory conditions, for example, pneumonia, and anxiety or panic attacks. A thorough evaluation is necessary to distinguish NSTEMI from these potential mimickers. The acute management of NSTEMI involves a multidisciplinary approach aimed at relieving symptoms, limiting myocardial damage, and preventing complications. Antiplatelet therapy, such as aspirin and P2Y12 inhibitors, for example, clopidogrel, ticagrelor, are prescribed to inhibit platelet aggregation and prevent further thrombus formation. Anticoagulant therapy, including heparin or low molecular weight heparin, is administered to prevent clot propagation. Additionally, the decision of whether to pursue invasive or conservative treatment strategies must be carefully considered, taking into account the patient's risk stratification and other clinical factors. In STEMI management, there are two approaches, invasive and conservative. Invasive procedures involve angiography, PCI or CAB to treat the culprit lesion. Conservative treatment optimizes medication and monitors the patient without immediate revascularization, with the choice based on patient factors. The long-term management of NSTEMI patients focuses on secondary prevention strategies to reduce the risk of future cardiovascular events. Lifestyle modifications, including smoking cessation, adoption of a healthy diet, regular exercise, and weight management, are crucial in maintaining cardiovascular health. Pharmacological interventions, such as statins, beta blockers, angiotensin-converting enzyme inhibitors or angiotensin receptor blockers, and antiplatelet therapy, are prescribed to optimize cardiovascular risk reduction. Additionally, comprehensive risk assessment and individualized management plans, including thorough patient education and close follow-up, are essential components of long-term NSTEMI management. NSTEMI can lead to complications like arrhythmias, heart failure, and cardiogenic shock. Arrhythmias can occur due to ischemia or reperfusion therapy. Heart failure can develop from myocardial damage and impaired ventricular function. Management includes medications, hemodynamic support, and mechanical circulatory support if needed. The prognosis and outcomes of NSTEMI patients depend on age, comorbidities, disease severity, and timely management. NSTEMI has lower mortality than STEMI but carries risks of recurrence, complications, and long-term morbidity. Early diagnosis, risk assessment, optimal management, secondary prevention, follow-up, and patient education are vital for improving outcomes. The field of NSTEMI management is characterized by ongoing research and the emergence of novel therapeutic strategies. Recent advancements include investigations into newer antiplatelet agents, such as P2Y12 inhibitors with more potent and rapid onset of action, and extended dual antiplatelet therapy duration. Additionally, the role of advanced imaging techniques, genetic testing, and biomarkers in risk stratification and tailored therapy is being explored. Ongoing clinical trials are evaluating the efficacy of newer anticoagulants, novel interventional techniques, and adjunctive pharmacotherapy in further improving outcomes for NSTEMI patients. To summarize, non-ST segment elevation myocardial infarction, NSTEMI, is a distinct form of heart attack requiring comprehensive knowledge for diagnosis, management, and prevention. Advancements in research and treatment are expected to improve patient outcomes in the future.